Good morning, everybody. I think we're live now and ready to go. So good morning, everyone, and welcome to our annual finance update for GP practices. It's lovely to see so many people have joined us again this year, and welcome to all of those who are joining us for the first time. My name's Kay, and I'm Head of Healthcare here at Duncan & Topless. We've got a specialist dedicated team to support our practices, ranging from services to act as a virtual finance manager, bookkeeping services, accounts, taxation, pensions, to multi-million-pound property deals and allowance claims, as well as VAT. Welcome also to the PCNs and federations that I know have joined us today too, and we'll be covering changes as well that will impact them. So today I'm going to be running through the contract changes for 25-26 before moving on to my usual tips, hints and hot topic session. So can I just ask if you've got any questions as we go through the session, that you note those in the chat section or the Q&A section, please, and I'll respond at the end. There will also be a feedback form sent to you shortly after the event, so if you do prefer, please do pop any questions in there. I am hoping to get to the Q&A section at the end, although this week myself and some of the healthcare management team attended the AISMA conference, so that's the Association of Independent Specialist Medical Accountants. And so I have brought into my presentation some thoughts and comments and updates that we gleaned over the last couple of days that I hope will be useful for you all. The conference speakers were all either GPs or professionals specialising in healthcare, so there was lots of interesting comments and content. So it's the 1st of May. The 2025-26 contract changes are here. What do they look like? So following what has been reported as positive and constructive engagement, GPC England has agreed to the 25-26 contract. However, moving forward, they don't want to keep renegotiating the old contract and are looking forward to a new one that we hope to hear more about later this year. Although obviously we are expecting, and at the conference it was mentioned that that's not going to be 2026, it might be 2027 or 2028, quite possibly before that's really sort of settled in. So the focus continues to be the push for care in the community and prevention, also to continue to move to a more digital way of working. There has been the removal of some red tape to allow greater freedom for GPs. We saw some changes in 24-25 with a backdated uplift to global sum from £107.57 to £112.50. And an extra £4.93 per person partway through to support the DDRB 6% uplift. Also, recently qualified GPs were added to the RS scheme with additional funding from October 2024. Locum reimbursements were also uplifted partway through the 24-25 year, and so any practices who claimed reimbursements were entitled to the uplift dating back to any claims from the 1st of April 2024, as well as claiming the higher amount from that point onwards. So if you did have any claims and you didn't request the uplift, you may want to be speaking to your ICB now. So this year sees the 889 million additional investments in the core contract and network contract DES, taking the overall investment to over £13 billion. The 889 million is assumed to cover an increase in salaries of 2.8% in 25-26, the continuation of GPs in Rs, other cost growth pressures such as premises and list size, as well as increased level of complexity and activity. 746 million of that is the global sum element. They are saying that the funding is expected to cover the extra staffing costs practices will see in respect to the changes to the NI rates and thresholds, as well as the increase in national living wage. But as the increases are based on weighted list size, we know that there will be practices who gain and practices who will still lose out, depending on how they're structured in respect of staffing. They've also commented that the calculation did not take into account the cost of maintaining wage differentials, which we know can also be costly for practices, especially when the national living wage increases as steeply as it has. Also remember, not only are uplifts based on weighted patient list size, but the contract is broken into 3 elements: the GP contractor income, staffing expenses and other expenses. The staff element used to represent around 44% of the standard contract amount, but with more recent increases, the BMA have said that the increases are now creating around 50% of the core contract being staff related. One key thing in discussions regarding a new contract will be around global sum increases to allow autonomy for a practice. Although we can see the increases to the R's budget for PCNs, and these are for additional roles, GPs and nurses, but they are core. It was raised in 25-26, but it ended up as a compromise, that those went through the R's budget rather than being viewed as core for a practice. A further uplift might be made later in the year following the DDRB report, the same as it was in the previous year. There's also 80 million for use of the ERS advice and guidance between GPs and consultants. So this is an opportunity to take part in a new enhanced service for advice and guidance, and its aim is to support the commitment to move more secondary care into community settings, and we'll look at this a bit later on. So what do the main changes mean for you and your practice? So I'm going to be looking at a review of the key areas of the GMS contract, a review of PCN income, impact of employee cost increases, and as I say, the tips and hints and hot topics section at the end. So let's start by looking at the practice level changes. You will see an increase in your global sum payment per weighted patient from £112.50 to the £121.79, so that's an uplift of 8.26% there. The GMS out of hours deduction remains at 4.75% in 2025-26. And there are, of course, the adjustments for not providing minor surgery, which are 0.6% of global sum. There's also been an increase in the value of the quality and outcomes framework, so the QOF point. That's from £220.62 up to £225.49. But if we then take into account the CPI uplift from £9,964 to £10,184, if your weighting has stayed the same and you achieve the same points, your money hasn't increased. It all works out to be the same. And actually, there are less points this year, as we'll see, and more focus on sum, which we'll talk about in a few minutes, but it does make it harder. To deliver an equitable and consistent approach to uplifting PMS and APMS contracts, commissioners will apply increases for those GMS changes that also impact on the arrangements for PMS and APMS contracts that are equivalent to the value of the increase in the GMS price per weighted patient. So that's £9.29 increase, the same as the global sum, except where local agreements with contractors set out a different approach to secure that equitable funding. Just a note there as well that the network participation payment will stay the same at £1.76, just over, per weighted patient. The 2025 contract changes are some of the most significant, with a dramatic shift to preventative care, particularly CVD, and aiming to streamline administrative tasks. So it's really important that practices understand the changes so that you can manage resource and workload efficiently and plan effectively to ensure financial stability. Make sure that you are aware of which activities you no longer are incentivised to do so that you can adjust your work accordingly. So looking through the QOF changes, 32 QOF indicators, which were income protected in 2024-25, have been retired. And that equates to 212 QOF points, worth around 298 million in 2025-26. So the easier wins have gone, and all of the remaining QOF income needs to be actively earned. You need to ensure that everything is being coded properly, that reliable IT is in place for the processes and data capture. Of the 212 points, 71 points have been removed, and they're being reinvested into global sum and into the increases that we're going to look at in both the item of service fee for routine childhood vaccinations and the locum reimbursement rates in the statement of financial entitlements. The remaining 141 QOF points are targeted towards CVD prevention, so that's cardiovascular disease. The points and funding are redistributed proportionately across 9 CVD prevention indicators. Lower thresholds for these indicators are maintained at 24-25 levels. The upper achievement levels have been raised for 25-26. The aim is to reduce mortality from heart disease and stroke by 25%. It's really important that practices look at how they deliver these relevant services to maximise this income. With so much funding tied to just 9 indicators, underperformance will have a much bigger impact than it has before. So do make sure that everyone who is involved recognises the financials around the CVD indicators and make sure that your systems are robust and start the processes as early as possible, monitoring regularly. There are also a small number of technical changes to be aware of. So the maximum QOF points achievable for 25-26 are 564. And your QOF payment is based on points achieved, point value, practice list size, and disease prevalence adjustments. If you do what you did last year, you're going to lose money in this area, especially in respect of those CVD indicators with the higher thresholds. And just a reminder here of the importance of the adjusted practice disease factor, which is your practice disease prevalence divided by the national average disease prevalence for a particular chronic disease, and is very important for maximising your QOF money. The higher the prevalence, the better, so very important to make sure you do have everyone registered correctly for each chronic disease. So personalised care adjustments, which we're exception reporting. This allows practices to differentiate between a few different reasons for adjusting care and removing a patient from the calculation. As with exception reporting, applying a PCA to a patient record will remove that patient from an indicator denominator if the QOF defined intervention hasn't been delivered. It will not result in patients being removed from the disease register or other target population. This mechanism differs from exclusions. There are strict do's and don'ts, obviously, around what and how to apply these, so you do have to be very careful, but ultimately these are also an impact on your QOF income. So do make sure you have gone through the information thoroughly and don't miss anything. There have been a lot of complaints regarding the PCA in respect of childhood immunisations. Nothing has been done for 2025-26, but there is a task force looking at how childhood IMS will be delivered in the future. Trying to be really careful with my slides now. So moving on to vaccine immunisations. Well, how many years has this payment remained static? At last, the item of service fee for routine childhood immunisations that are part of essential services will increase, and that will increase by £2 to £12.06. And the 2025-26 Statement of Financial Entitlement will list all the vaccinations and immunisations which are in the scope of this increase. It does also apply to Hep B, IMS at birth, 4 weeks and 12 months, and MMR for those 6 and over. Unfortunately, the increase doesn't apply to all vaccine IMS, so anything not on that list will remain at £10.06. 17.8 million of the funding generated through those retired QOF indicators have been used to cover the estimated costs of this increase. Quick mention here, re the flus. So flus were not uplifted, with the reason being given that there was not enough in the pot for GP practices and community pharmacies who also deliver flu campaigns. Locum reimbursement payments, so the rates have been uplifted to take into account the DDRB increases over recent years, and the new rates will be £1,418.43 for the first 2 weeks of parental leave, followed by £2,151.96 per week. For sick leave, obviously the first 2 weeks don't attract any reimbursement, but it will be £2,151.96 per week thereafter. Prolonged study leave, £1,404.38 per week, and suspension, £1,404.38 per week. And remember, you can claim not just for locum cover, but also if a salaried GP or partner is covering, providing that they're not already working full-time. This isn't prorated, so good for people trying to cover a part-time worker, Not so good when you're trying to cover someone who carries out more sessions, as the reimbursement may well still not cover the costs. The weight management enhanced service continues for 25-26 with an unchanged item of service payment of £11.50 per referral and capped funding at 7.2 million. So this is the same as last year and the year before. I mentioned the new enhanced service, so 2025-26 sees the new enhanced service for pre-referral advice and guidance, and that attracts a £20 item of service fee per request by GPs. That's £20 per episode of care. You don't get any additional referral fees for multiple contacts regarding the same clinical issue. And the referral must be GP-led, so either initiated by or reviewed by a GP ahead of submission. This service was available on CQRS from yesterday, and commissioners have to invite you all to participate no longer than the 13th of this month, and then you have until the 27th of May to sign up. Any claims can then be backdated to the 1st of April. And this funding flows through the ICB, and you need to be making monthly claims via CQRS for approval by your ICB. And those claims should be made no longer than 12 days after the month end when the pre-referral advice and guidance was given. One thing to note here is that the ICB have the ability to cap the amount of requests that will be paid for. If they change the cap in the year, they can't set it at a lower level than has already been delivered. The ICB has to notify practices of any cap they apply, and this will be potentially different across different ICBs. It doesn't have to be the same. So it's really important, again, that you record all of your advice and guidance requests correctly. They have to be recorded correctly in order to claim for all eligible interactions from the 1st of April 2025 using the appropriate SNOMED CT code. Advice and guidance in the enhanced service is defined as GP-led, non-face-to-face activity, which could be real-time synchronous advice such as a telephone call, or asynchronous advice when carried out electronically through the NHS e-referral service or dedicated email addresses. Again, ongoing communication between the referrer and the respondent regarding the same episode of care won't attract a further item of service fee. So just something else to be aware of there when you're looking at level of work and payments that you receive. Bit of a mention on IT and digital. So from the 1st of October 25, practices will be required to allow patients to submit routine non-urgent appointment requests, medication queries and admin requests via online consultation tools during core hours. The design and implementation is being reviewed in the coming months to ensure that there are safeguards against urgent requests being submitted in this way. GP Connect. By the October 2025, practices will be required to ensure read-only access is available in GP Connect for other NHS Commission providers for direct patient care, and also for private providers where the patient has been given permission and they are providing direct care. GP Connect will also allow community pharmacy registered professionals to send consultation summaries in GP practice workflow, enabling a reduction in administration for practice teams. Just a few more mentions of some other changes. So patient safety strategy. So the primary care patient safety strategy was published in September 24. And in 25-26, GP practices will have to have regard to this and also register for an administrator account, unless their local risk management system is already connected, with the Learn from Patient Safety Events service for the purposes of recording patient safety events at the practice about the services delivered by them, thereby contributing to the national NHS-wide data source to support learning improvement and learning culture. Also enabling the practice to record patient safety events occurring in other healthcare settings. For example, if a GP practice wished to record an unsafe discharge from hospital. And also individuals recording patient safety events being able to download a copy of the record for purposes of supporting appraisal and revalidation. Safe and effective provision of high quality primary medical services to patients registered out of area. So there'll be a contractual requirement that GP contractors work collaboratively with commissioners to implement out of area registration. And that will provide safeguards when practice lists are expanding rapidly with the registration of out of area patients. Contractors will need to get approval of plans to enable oversight of the safety and effectiveness of the arrangements so patients can access the full range of primary medical services. There's a note around dissolution of partnerships. So the GP contract regulations have been amended to make sure that GMS contracts can be terminated in a situation where there's no clear successor when a partnership dissolves. There were some more notes around violent patients, so the process for patient removals being made clearer in the regulations in a way that protects the rights of practices to immediately remove violent patients, whilst they ensure that patient choice is retained when patients have not been immediately removed from their previous practice. So it's important practices process the removal of violent and threatening patients immediately and report to the police within the period set out in the regulations. Police reports made after this period should not necessarily affect patient choice of alternative provider and should not necessarily mean that the patient requires allocation through the special allocation scheme. And finally there, managing patient lists. So there have been amendments that have been made to enable NHS England to contact a patient digitally as opposed to in writing when it becomes aware that the patient has moved from the practice area, and that will allow additional routes for NHS England, it still is at the minute, to advise the patient to either obtain the contractor's agreement to remain on the contractor's list of patients or to apply for registration with another provider of essential services. And the notice time frame for deregistration is being reduced from 6 months to 3 months when a patient is no longer known to NHS England. A couple of other further changes to the SFE, and that's the adjustment factor for care homes and dispensing payments. So there are additional amendments to clarify that the adjustment to global sum for care home patients should only apply to CQC registered nursing and residential homes. And claims for your high volume personally administered vaccines can now be sent via the new digital portal, or you can continue via the current postal process. So moving on to PCNs, more of a challenge for PCNs because excluding the additional investment in GPs, there's very little uplift, as we will see, and no other substantive changes other than ours. There have been simplification of service specifications, so the previous 8 PCN service specifications have been rolled into one. And there's a focus on coordinating, organising and deploying shared resources to support and improve resilience and care delivery at both PCN and practice level, improving health outcomes for patients through effective population health management and reducing health inequalities, targeting resources and efforts in the most effective way. And that's looking at delivering proactive care and collaborating with non-GP providers to provide better care as part of an integrated neighbourhood team. So as you'll recall, there was a mid-year update to figures that was then backdated to the 1st of April 2024. The enhanced access payment has gone up from £7.97.5 to £8.427. And is multiplied by the PCN's adjusted population at the 1st of January 25. That's paid monthly. Core PCN funding, which includes the old 2023 Clinical Director and Leadership funding, which was merged last year, has increased from £2.96 to £2.99. Some of that, the bulk of that, is multiplied by the PCN registered list size at the 1st of January 25, and the remainder is multiplied by the PCN adjusted population at the 1st of January 25. Capacity and access support payment continues and it remains unconditional for PCNs, and that payment is £3.20, just over £3.20, multiplied by the PCN's adjusted population. That was previously £3.24. So a drop of 4 pence there. The capacity and access improvement payment also continues, but has changed from 3 domains to 2, and the payments of £1.37.5 were down from £1.39 multiplied by the PCN's adjusted population, so a drop of 1.7 pence. One domain will be continuing to focus on supporting modern general practice access, while the other will incentivise PCNs to use the intelligence gained from population health risk stratification tools to stratify their patients, including to identify those that would benefit most from continuity of care. We've then got the Rs, the additional roles reimbursement sum, and that equates to just over £26.63 multiplied by the PCN contractor weighted population. And that compares to £22.67 last year. Plus it incorporates the prior year £1.30 Rs GP sum, which was actually just for 6 months. So the fair comparison of that is adding just over £2.60. So you're looking at an annualised uplift from £25.50 to £26.63, so 4.4%. And finally, the care home premium, which has gone up this year to £130.25 from the £127.20 last year. As mentioned there, the IIFs, the Investment and Impact Fund, the amount payable is dependent on achievement, so it's the PCN equivalent of QOF, and there remains no change. So 58 achievable points at £198, no change compared to last year. So in respect of the additional roles reimbursement scheme, GPC England tried for a practice level GP employment scheme, but it was eventually agreed to merge the GPs in Rs and regular Rs pot as a short-term measure in 25-26, which is argued to give PCNs and practices within them the opportunity to look at staffing structures in respect of GPs and the nursing team. And this will be revisited in the negotiations for 2026-27. The scheme is more flexible in the coming year to allow PCNs to respond to local workforce requirements. As I say, GPs are added into the main scheme, as are nurses. The current 2 pots of Rs funding has been combined together into a single fund for reimbursement of patient-facing staff costs without restriction on numbers or type of staff, including GPs, but the cap is on your funding envelope. Each PCN has a set Rs funding allocation based on the PCN adjusted population. The roles must be additional to existing workforce, must meet specific training and qualification requirements, and require appropriate clinical supervision. The additional roles for 2025-26 are here on screen, so the mental health practitioner for children and young people, new to general practice nurse, experienced general practice nurse, consultant nurse, primary care, healthcare support worker, advanced practitioner, i.e. physio, dietitian or OT, paramedic, mental health, consultant nurse, advanced practitioners. So lots of flexibility, but not a lot of funding to support the ability to recruit. And just remember, you can't use Rs to backfill existing staff. You can't claim for recent staff, for example, nurses who have worked for the network in the past 12 months, unless you're giving them a promotion for specialist roles. So you can claim for nurses promoted to specialist roles, supporting career progression. Stay on there for a minute. So the salary element of the maximum reimbursement amount that PCNs can claim for eligible GPs will be increased from £73,113 in 2024-25, so the bottom of the salaried GP pay range, to £82,418. So that's an uplift of £9,305, representing the lower quartile of the salaried GP range, reflecting that some GPs will be entering their second year in the scheme. Proportionate employer on costs would also be included within that overall maximum reimbursement amount, which PCNs will be able to claim. And the criteria for eligible GPs remains the same as it was before. So those are the main contract changes as they stand, and practices do need to be fully aware of those contract changes and the impact that they will have on funding and workload. So what might the future hold? So it's believed that the current government are committed to the partnership model, despite previous comments. Limited liability partnership models are being discussed. The hope is that funding would be based on registered list sizes to deliver core services, with more funding being ploughed into the global sum to allow flexibility for practices. A new formula for capitation, a review of incentives and item service fees, as well as key areas such as premises, IT and staffing. Also to look at other opportunities in respect of private income, which has been constrained over the last few years. So let's see what the 10-year plan brings for health, which we will hopefully know more about in June. And the focus is believed to be hospital to community, treatment to prevention, and analogue to digital. The other big thing that hopefully you're aware of by now is the impact on your finances of the staffing cost changes. So national living wage increased, as we can see here on this slide, so a large increase for practices, especially when looking at the potential knock-on impact to other wages where you are trying to maintain a fair differential. National insurance has also created a high cost increase, and so it is essential to look at how this will impact your cash flow and budget this year. So for each employee earning over £9,100, it's costing you an additional £615 plus 1.2% of anything over 9,100. So that £615 arises because the threshold changed from 9,100 to £5,000. So if they're earning over that's your £615 plus your 1.2% on anything over the 9,100. So it's essential now more than ever that practices do look carefully at their current and future strategies, particularly with regard to time and resources. And collaboration across primary care networks is key, as well as internally within the practice. The highest proportion of practices' income is contract income, generally over half of practices' income, and the rest is made up from your QOF, your enhanced service income, other NHS income, other non-NHS income, your rent reimbursements of notional rent, maybe some cost rent left out there. So what do you need to be doing? Well, firstly, for anyone not preparing budgets or forecasting cash flow, you really need to be asking your accountant too, if you're not doing it yourself internally. It's absolutely essential for practice cash flow that you are monitoring these so that you can react in plenty of time if there are likely to be any pinch points. Partners in practices have been having to review their drawings levels, and in some practices we do see a lack of understanding that any shortfall does have to be covered by them out of drawings, as it is all of their money. So preparing budgets and forecasts also helps you to keep on top of your cash flow issues, such as numerous problems that we see with salary GP pensions, for example. You need to be educating your team. You need to make sure that you're communicating with them. They need to be aware of their impact on the finances. And this can be from the right person doing the right job, signposting, a full awareness of financial implications of whatever role they play. So, for example, clinical team, that they're performing services that you can claim for. Are they aware of what they should be coding and the financial implications if they miss anything? We have already talked about QOF and the importance of coding correctly, being aware of the changes this year and prevalence and personalised care adjustments. You need to make sure everyone is aware of the correct up-to-date codes needed, especially where you have temporary staff and templates aren't automatically updated. Ensure claims are submitted as required. Are the finance team aware what has been claimed to enable them to ensure the money does come in and that it is correct? Remember, there are deadlines on back claims for a number of income streams. I've done training sessions with practice staff, and it is amazing how many haven't been aware of the financial implications of their actions in respect of coding. So do make sure that you code everything correctly. And we'll cover some more on income shortly. Patient education as well. So the flus is a prime example. Be open and honest. No one wants to think that their local surgery is at risk of closure. Tell them that you need them to come in to you if you're going to be running the flu clinics. Flu should be a really good source of income if it's dealt with efficiently. And again, we'll come on to that shortly. Communicate information to your patients that may help them understand things. For example, why they don't always need to see a doctor, what they can do to help you be more efficient so that you remain viable. Just be honest with them. Are you charging for everything that you can? So in respect of private fees, and are they at an appropriate level? When did you last review those? When did you have your notional rent review? Get it checked. Don't just let GPs automatically sign and agree it. We have seen lots of reviews, and there's some really great firms out there supporting practices to maximise their notional rent income. Are you providing any services that you're not getting paid for providing? And if you are, why? Is there a good business reason for doing it? If not, could this work be replaced with work that you can get funding for? Meeting clinical targets and QOF targets. Effective use of resources. Ensuring that all of the team is fully utilised. If not, what income could they be generating? Can you cover a number of patient issues in one visit and create efficiencies? Purchasing effectively. So this isn't necessarily looking for the cheapest, this is looking for the best value for money, and consider where you cut costs and the knock-on impact. So don't cut costs in areas that can add value or that may cause you issues further down the line. A classic example would be not to cut costs on partnership agreements, and we have heard some horror stories and seen some horror stories, so do get them done properly. You may need those partnership agreements to stand up in court one day, and one that a partner in the practice may have cobbled together from various previous documents is not going to cut it. Other issues, cutting costs on accountants and using ones who have no experience in NHS pensions or aren't medical specialists. I've seen one or two issues with some claiming to be medical specialists, just to say now they are not ASMA firms. Experience in NHS pensions, leaving partners with incorrect pensions and causing huge cash flow problems. So we have seen this where we have taken on practices from non-specialists. You know, and that results in larger costs further down the line trying to sort it all out. So you need to be ensuring you're using someone that does at least understand pension superannuation, because it can have a massive impact. We were only talking earlier this week with MediFintech, incorrect certificates, impact on annual allowance tax paid and long-term pension benefits can be quite horrific. Effective communication with patients. What is the quickest and cheapest option, but ensuring it's in line with patient abilities? And on this note, we had a talk from Dr. Gandhi around the fact that there will be an issue this year, potentially, in practices in respect of costs incurred for text messaging. So text messaging patients, the ICBs had covered the actual costs, but the actual costs were actually at least 3 times more than the budget. The cost of 160 characters being 3.7 pence plus VAT, and that all adds up very, very quickly. So practices are potentially going to feel the hit of additional costs there, and will be needing to look and adapt communications with patients. More information to follow on that. Few reminders around drugs profits. So for dispensing and non-dispensing practices, especially as there are declining refunds and fluctuating dispensing fees. Ash Lane spoke at the ASMA conference this week, and so I have woven in some of their tips and hints here. They're predicting an increase in overall revenue for an average 10,000 non-dispensing practice, but a drop in margin to around 21% from 25%. For dispensing practices, there was just a note to make sure that you're maximising your dispensing patient numbers. For all of you, make sure with your PA items that everything used is recorded so it can be claimed. Make sure that everyone is aware of what can and can't be claimed. So an example would be sutures. Certain sizes are claimable, certain sizes aren't claimable. And also pessaries too, they're not all claimable. So make sure that you are buying and using the ones that you can claim, and you are recording the correct ones to maximise those claims. Make sure you're splitting out your claimable and non-claimable items in your accounting software so you can accurately monitor overall profitability. Do you have a method of checking each month? Make sure the team know on the larger items at least what the refund rate is each month, and ensure that they're buying at a rate that will make a profit. And don't forget to take into account any discounts and also VAT. So for example, Morena's, you actually only pay 5% VAT, but the PPA refund 20%. So you need to make sure when you're comparing both the income side and the cost side, you are looking at the full picture. If you won't make a profit on a certain drug, is there an alternative that you will? Don't forget to spread scripts out across doctors so you don't lose out on dispensing fees with it being a sliding scale. Be savvy with your dispensing fees, which are based on items dispensed. Flus. Don't order late and get charged extra. Remember that sale and return is limited now, so don't over order, otherwise you will be trying to sell on to get some money back. Don't over order on any stock that may risk going out of date and having to be disposed of. Be aware of supplier premiums. It's convenient to order through one supplier, but sometimes it can be costly. It's weighing up that convenience, isn't it? Higher cost drugs require more attention as they can tend to be loss-making and also can soon impact if any become out of date or no longer needed because you've ordered them in for a patient who may then no longer need them. Prostat can be really profitable as it attracts the most discount, but only with one supplier according to Ash Lane. So really do look closely at the discounts that suppliers can give you. A really top tip that they gave yesterday was be careful with the flus this year. So teams will have got used to claiming for the same flu vaccine over the last few years. But this year there is a change in the drug and pricing. So for example, for the over 65s, the new drug is worth £17.55 reimbursement, whereas the one previously used is £13.50. So that's a really big difference. And Ash Lane were advising that you make sure the person claiming looks at the box to make sure there is no risk of incorrect claims that will cost practices a lot of money. On the topic of flus, some more tips and hints they gave were not to trust the flu supplier's forecast of profit, calculate it yourself. Don't just go for the cheapest flu vaccine, go for the most reliable supplier, as any delays in delivery will cause losses. When doing your flu campaigns, look at how they're delivered. What else can you be doing whilst you have the patient in to make the process even more profitable? Although flu income will be up, profits will be down, but if processes are followed and you get it right, it will still be a healthy income stream. Make sure that the number of flus claimed corresponds to the number of flus purchased and used. And there have been occasions that we have seen this hasn't been the case and there have been underclaims. It's much easier to monitor and deal with any issues as you go along at that time, rather than trying to claim a back claim. So do monitor that what you're purchasing and using does equate to the number that you are claiming for. There may be items that you just can't make a profit on, so consider writing a script for those. And I appreciate that will depend on where the nearest pharmacy is and the impact on the patients, but it's worth a thought. Ensure scripts are correctly completed so that you don't lose money on script fees as well. Consider outsourcing the checking of drugs income because it currently passes through so many hands in the practice and PCSE. For as little as, I know it was £60 plus VAT, I'm not sure what they are now, but it won't be too far adrift. You could have those checks done for you by someone, Ash Lane, with the necessary IT links. Yes, an extra cost, but it is going to find you more income and save internal costs of that work. Of course, the other issue here is the dispensing fees keep moving and sometimes quite significantly, which isn't helpful for you. I know there are people here today who have used Ash Lane and benefited from the fantastic work that they do, especially supporting up to 6 years back claims and identifying and fixing any underlying issues. Another note there is just for any practices who wholesale. So it is really important to try and ensure wholesaling costs are also coded separately. I know it can be difficult, but if it isn't, or you don't attempt to do as good a split as you possibly can, how are you going to ensure that your regular surgery claims are as profitable as they should be if the figures are all together? So we've touched on the biggest cost is obviously staffing costs and locums. We've mentioned earlier the contract uplift is more generous this year, but there will still be winners and losers in respect of the uplift versus the cost of staffing increases and extra NI, depending on how your practice is structured. So careful consideration is needed in respect of salary increases to balance affordability and retention of good team members. Practices I know reviewing contracts continually for any new employees, particularly around overtime rates and sickness policies, in respect of how that will impact on your finances. Also consider job roles and duties. Can you cross-skill your staff more to assist with holidays and sickness cover, for example? Make sure you're planning holidays and cover well in advance, because that will really assist with the cost of cover. The sooner you can get the team to agree holiday dates, the more likely you are to be able to ensure that you've got sufficient cover in the existing team as much as possible without incurring too many additional costs. And I appreciate that will depend on roles. But the more time to plan, the more cost-effective cover usually. Use of the R's roles. So in 2019, we saw the introduction of primary care networks. GP practices were really pushed to join or risk lose funding. And these were to group practices together to achieve the benefits of working at scale, look at more efficient working by working together across practices and with community services, and to reduce healthcare inequalities. And it was aimed to give the ability to hire additional staff and manage escalating workloads. So you need to make sure that you are aware of what's going on in your PCN and what you can do to maximise your income share or access staff. Be aware of what's happening in your federation too, if you're part of a federation. If you're one of the practices that are listening and who are really aware of what's going on in the locality with the PCNs and the federations, the ICB, then that's great. You know, you really need to be talking to them, working with them, making sure that you're getting the best out of them. And I know that there are some fantastic ones out there that really support their practices. Equally, we have seen some pretty shocking ones. So you really do just need to make sure that you're getting the most out of them. Have you had a business cost consultant in recently? So they don't cost anything, but they can save you a lot. The one we used to use as a firm, or we use as a firm, has been out to various practices over the years and supported cost reductions with some fairly simple wins at times and no reduction in quality, but some really good savings. One thing I haven't mentioned so far are area specific, so around how enhanced services are paid locally, as there are various people from various areas here today, and so different methods of payments are out there, you know, in different areas. So you do need to be aware of any changes and how that's going to impact your practice as well. There are differences in local funding across the UK for some of the enhanced services. Be aware of any local incentive schemes that are available and any one-off funding as well. Some hot topics next. I'm conscious of the time. I am close to the end. Some hot topics next. So the McLeod judgment. There's a lot of work required around this. The annual allowance tax, contributions, tax relief on contributions, all needing to be considered. There are various scenarios where compensation has been agreed for professional fees in respect to the calculations that will be needed. For some it's capped and some it's not. We have started work, but a lot of the RPSS, the remediable pension statements coming out are incorrect still, and a huge volume of them that should have come out have still not been issued because of all the problems. But the key thing here is that because NHS pensions have been reviewing service records, there have been a lot of PCSE cases opened requesting certificates, and these must be updated in order for any GPs, especially those impacted by McLeod, to be able to receive their RPSS. Although currently, as I say, that those are wrong, but it is really important now to be getting those service records up to date. So we need GPs to ensure that they're not ignoring any emails they receive from PCSE in respect of missing certificates. Please do send them in. Tell your GPs to send them in. Or if you're dealing with them, tell them to send them to you. There will be a huge amount of work for PCSE to get all of the missing ones processed, and they are getting a special resolution team in place to deal with the added workload. There are also, as PCSE advised us at the ASMA conference this week, many salaried GPs who haven't completed their Type 2 certificates still. And these had to be submitted manually this year, just as they did for the Type 1s, so for your partners. PCSE are actually retrospectively creating an online version for 23-24 for the Type 2 certificates, so for the salaried GP, and that should be available by the middle of this month. So any Type 2 practitioners who haven't completed their 23-24 certificate, they will be able to do it online once it's released later this month. But their records can't be updated if they have older years outstanding, just the same as anybody else. We have been contacted by quite a few salaried GPs who are worried about their pensions, and we have been supporting them with getting their records up to date, and in some cases checking and resubmitting Type 2 certificates as necessary. So if you do have any salaried GPs having a panic, we can help. Feel free to pass on our details. I mentioned notional rent reviews earlier, so just a reminder that partners don't just sign off the notional rent review. It is really worth getting a second opinion to make sure you maximise that income. We often see surveyors finding practices some more money. NHS sickness claims, I did mention earlier, just another reminder that you can claim for GP partners covering, as long as they're not full-time. Just need to send in an invoice. It can go through the practice accounts as an extra session. The accountants can adjust for it in that way. So, but make sure you get all the money you can in. Making tax digital, otherwise known as MTD. So this might be something. I know we did do some webinars and put out some mail shots quite a while ago, because originally it was announced in 2015 and it was intended to be fully implemented by 2020, but it's been delayed and delayed. So from April 2026, self-employed individuals, so that includes GPs who are sole traders, and landlords earning over 50,000 will be required to maintain digital tax records that are MTD compliant and submit updates every quarter. So you will have to ensure that your data is well analysed on a compliant system and up to date every quarter for submission. And I know there are very few, but some practices don't use their software to its full potential, as they perhaps use spreadsheets sitting to the side. And those practices are going to have to be up to date with their bookkeeping and analysing data properly on the system. So as I say, that's coming in for sole traders from April 2026. For partnerships, the date hasn't been confirmed yet, so watch this space. We'll be putting out mail shots and letting people know when we know more. Finally, a few reminders. So PCSE and superannuation issues, joiner and leaver forms. I mentioned last year that PCSE were looking for a smoother process for that. It is still being worked on. Nothing has been completed yet. There is detailed guidance on PCSE website. The process is required. The leaver process is very straightforward and can be actioned by the practice, but the joiner process relies on various steps, from the GP joiner updating the performers list, then the practice confirming and the completion of the joiner form. Another issue is often the SD numbers, so the pension numbers, and that'll be on any NHS pension correspondence, total reward statements, or they can phone NHS pension. So it's just making sure you've got all the information there and you've started the process correctly. Estimate of superannuable profit forms, so don't forget to update these throughout the year for changes in salary for salaried GPs, as well as joiners, leavers, people opting in or out, and changes to partnership profit shares. PCN profits for inclusion in practice accounts. So remember, profits from the unincorporated part of a PCN do need declaring in member practice accounts. So make sure you are getting a set of accounts from your PCN. Some are fantastic at sending accounts through. Obviously, we act for a lot of PCNs, but there are PCNs that we don't act for, that our practices are involved in, and we have seen the odd issue with trying to get any accounts out of them. For practices who are on the call, make sure that you are liaising with your PCN and pushing for transparency, and you want to see those figures. The PCNs that are on the call, it's never the ones that are sitting on training sessions and talking that are the ones that are the issue. So new pension tiers and pay rises. So this is a reminder to be mindful of the pension tiers for staff and salaried GPs. So when you're giving pay rises, or when you're paying salaried GPs for extra sessions, although there's not quite the jump that there was in the tiers, we have seen over the past few years, just £1 into the next tier gives them no more pension, but they have to pay the higher rate on all of their income. So just watch where they are close to the next tier, if something they're going to do is worth it or not, because you might just have, if we use a salaried GP doing an extra session as an example, if that salaried GP does an extra session, it just tips them over into the next tier. They have wiped out the pay for that extra session and more in contributions, pension contributions, at really no extra benefit. So do watch that, or remind the salaried GPs to watch that. Not helpful, I know, when you're trying to get extra sessions covered, but GP earnings declaration. So this is the website one. The ridiculous and meaningless figure still has to be calculated and declared on your websites. We keep hoping that that will disappear and they'll stop doing it, and it won't be part of the contract, but they haven't done yet. Declaring GP earnings over the threshold is 163,000 based on the March 24 accounts. That's superannuable income, not total income, and the deadline was yesterday. Although I have, I think, conversations from last year, I'm not sure anybody actually declared it last year at all. Partnership agreements, another reminder here of how important these are. And I know I mentioned earlier, make sure they are up to date, they are accurate, use a medical specialist. We have seen horror stories, again, where practices haven't used a medical specialist and haven't thought of all the clauses that do need including. And please, please, please don't tailor them yourself. They are there for a reason, and you might not think you've got a problem with you within the partnership you're in, but sometimes you can get a surprise. So you do need them for your own protection. One or two more comments and considerations from ASMA. I promise I am nearly finished. I'm sorry I've run over 15 minutes. So one or two more comments and consideration from ASMA that I haven't already swept up in the above. So premises, leases, is there a minimum number of partners that you have to have listed on your lease? And if so, what are you going to do if that partner number goes below that number? So if you've got partners leaving and it goes below the number that you need on that lease, so something to consider. Freehold, don't forget to keep the title deeds up to date. It can become a costly problem to change at a later date, especially if a retired partner has passed away. One issue we've seen is where there is a delay on the repayment when a partner leaves, so when they've sold their share of the property or are trying to sell their share of the property. So make sure that the partnership agreement is up to date and clearly says what needs to happen when, and what the outgoing partner is entitled to if they are not going to be getting their money for a while. So that's considerations such as, is there entitlement to notional rent? Is there entitlement to interest because they haven't got their money yet? Finally, a few notes. We will be running a few free webinars throughout the year. So in June, Will Ellis from BW Surveyors will be joining me to discuss 10 top tips in respect of properties and the new premises directive that came in last year. And I'll be covering associated taxes and accounting for properties, and that will incorporate leases as well as freehold. In July, the new Managing Director of Castlegate Financial Services will be joining me and delivering a session looking at managing wealth, including investment opportunities with pension lump sums, as well as opportunities for investing for the future. I'm also in talks with Ash Lane, arranging a webinar for later in the year for them, again, to look at how they support practices and maximising drug profits. Also, a note there, myself and some of the team are attending a talk by DR Solicitors with an update on the NHS service charge cost issues. So for those of you who we look after and still have issues, with those, with the service charge costs, we will be in touch after that. So do look out for our future events. It'll be great to see you join us. I will have a look and see if we have any questions. So with capacity and access and the advice and guidance, have we got any suggestions how the ICBs will approach this? In particular, how likely is money to last in the year? And that is going to be a very individual ICB question, and it is absolutely key to be talking to the ICBs to see what your individual ICB approach is going to be on that, if there is likely to be any cap, because again it's moving back to what money are you seeing coming in, at what point do you where do you shift your focus to make sure you've got the money in to the practice, support all these escalating costs, particularly obviously around the workforce chaos that we're seeing with all the added costs. I'd just like to say thank you again to everybody for joining me this morning. It's great to see, I think 75 signed up for it, which is fantastic, and I know we've got some more just asked to be sent the link because they weren't going to be able to attend, so that's brilliant. I hope you found the session useful. I apologise, not everything was on the slides, but that was because I did bring some more things in following the ASMA conference, which was quite nicely timed with some fantastic speakers and some top tips and hints as we went through. Apologies again for the little IT glitch at the beginning. And I hope you all have a great day. Thank you for joining.